All right, so the objectives for this talk then, we're going to talk about the concept of synthetic lethality in the context of BRCA deficient tumors. I mean, what does this really mean once you know that your patient with prostate cancer has a BRCA deficient tumor, and the role of PARP inhibitors in that? We're going to talk about the basics. We'll start with talking about ovarian cancer, the role of germline BRCA status and treatment. We'll talk to resistance to PARP inhibition, this concept of reversion mutations. Gets back to the concept that was drilled into me in fellowship training that the dumbest cancer is still smarter than the smartest oncologist. We'll talk about, you know what, I took this article out in the interest of time, but I'll talk about it nevertheless, the potential to detect reversion mutations. Cell-free DNA is definitely a technology platform that is coming into its own, and why all this matters. All right, so the first set of slides I won't spend too much time on. You've already heard a lot about this. BRCA1 and 2 are common in prostate cancer, much more so than you might think. Different than breast and ovarian cancer, BRCA2 is somewhat more predominant over BRCA1 and appears to have a greater impact in terms of the relative risk of cancer compared to patients who are germline wild type. So BRCA2 patients have perhaps an 8-9-fold increased risk of developing prostate cancer, BRCA1 about a 3- to 4-fold increased risk. BRCA2, more so than BRCA1, is clearly associated with higher Gleason score at diagnosis, higher stage, and younger age of diagnosis. By NCCN Guidelines, these patients are considered high risk, and the guidelines would talk about PSA screening starting at age 45. Now, the guidelines have only recently been updated, so this might not be disseminated yet. Recognize that the positive predictive value of a PSA greater than 3 for predicting a positive biopsy is not changed, but you're much more likely to find a high Gleason, an intermediate or high-risk cancer rather than that low Gleason cancer. The risk of higher intermediate risk 3- to 4-fold higher in the patient with a BRCA2 deficiency. And note that amongst patients with lethal prostate cancer with known germline mutations of BRCA1, 2, or ATM, up to 60% of them are going to report a negative family history. So this is one of the key points we want to take home. We rely a lot on family history, on this pre-test probability in order to order genetic testing in the first place. And I think this is the key mistake we're making, and I'm going to show you some more data feeding into this. We are vastly underdiagnosing the frequency of these mutations, and this gets into what David was talking about earlier, where his patient's sister then ends up dying of triple-negative breast cancer, and he's asking the question, could I have prevented this had I been looking for the gene mutation? And 2 years ago, probably people weren't talking about this at all, or at least the majority of people weren't talking about this, but the time has come to change this conversation. The answer is yes, we can save lives by identifying high-risk patients early. Triple-negative breast cancer is a bad disease. Patient might have died anyway, but nevertheless, we're going to save some lives. We're going to decrease mortality. The best way to decrease mortality in cancer, as you all know, and I say this as an oncologist, the best way to decrease mortality for prostate cancer is never to let the patient get to me in the first place, right? It's diagnose them early, let the urologist treat them, cure them with the prostatectomy, and don't let them advance the point where they meet the medical oncologist. So this was a very important presentation we saw at ASCO this past year, and if you haven't seen this, you really need to go back and look at this paper. It was in JCO in May. And what this looked at was 1,158 patients with localized prostate cancer who had had germline testing done. They retrospectively examined these patients from multiple institutions and then applied a broader panel of testing beyond what had already been done. And in these 1,158 patients, they found 199 patients with a high-risk mutation, 199 out of 1,158. Okay, I mean, these are impressive numbers, right? BRCA 1 or 2, ATM, a list, and we'll get into the list a bit more, of other high-risk inherited germline mutations. And of those patients, of those 199 patients in whom the high-risk germline mutation was found, only 63 of them, with 63% of them, that is, would have been referred for germline testing if you followed published guidelines. So the point here is that published guidelines are inadequate. It's not enough to say, do you have family members who were diagnosed? Do you have, is it your father? Is it your brother? Guidelines like that don't work if your patient's an orphan. But if your patient's an orphan and he has 4 children, it still matters, right? What if, he's an only child? Or, you're seeing a woman, not prostate cancer, obviously, and she's an only child. Parents are only children. The number of people in the family is low. And so all these metrics we use that talk about the number of family members representing a cutoff are inherently flawed. You can't use these well in patients who come from small families, okay? So published guidelines as they currently exist are clearly inadequate, and this is a major issue in cancer screening today and in genetic screening today, and something that, in academia we're actively addressing, trying to find out how do we expand the definition, make sure we identify the right patients in the first place. Talk about all of your young patients ought to be tested. You get a man in his 40s with prostate cancer. I would say that should be automatic. You got to send him to the genetic counselor to talk about germline testing. In 2017, we can now say this ought to be done, right? In 2010, we weren't thinking about it, but in 2017, we got to be doing this. So the conclusion of this study is that genetic testing guidelines are not reliable. If you take home one message from anything I say, please take home this one. Think about germline testing far more often because we will save lives by identifying high-risk patients early. This is about cure. In medical oncology, the world I live in, I start talking to you about 2-month survival benefit, 3-month survival benefit, and most people glaze over and say, why do we care about 2-month survival benefit? We're talking about cure here through early detection. All right, so you already saw this paper, so I won't spend too much time on it. But it's an important paper because this is looking at men with metastatic disease and looking at this panel of known inheritable cancer risk genes, mutations. And what you see is that the overall rate is far higher than anyone expected. I mean, we were all trained with that kind of baseline knowledge of 1% to 2% of all prostate cancers have a mutation in BRCA. Probably we didn't talk about anything else beyond that. But here in this metastatic population, they start looking at 10 to 12% of all patients with metastatic prostate cancer have a germline defect, familial defect, 10 to 12%. So you talk about the utility of a screening test. A screening test that is going to detect the screened abnormality in 10 to 12% of patients is good enough for widespread use, right? That's higher than what you get with mammography. It's higher than what you get with colonoscopy. It's higher than what you get with any of the standard screening tests we think about. This data alone should tell us that every man with metastatic prostate cancer should have germline testing done. A 10 to 12% chance you're going to find something that is relevant to his family and ultimately to the patient. And I'm going to go on to show you why this matters to the patient today and how he's going to be treated. As you've heard, this isn't limited to just BRCA1, 2. This also impacts other cancers. So the Lynch syndrome family of genes, which you typically think about applying to colon cancer, but also has implications for upper tract urothelial cancer, uterine cancer, other malignancies, carry an increased risk of prostate cancer. Maybe a 8-fold increased risk of prostate cancer over baseline in early prostate cancer. Right, so again, 10 to 12% of these patients are going to have some kind of germline deficiency. We need to be testing these men. So why does this matter in terms of my patients in my clinic when I'm trying to decide how I'm going to treat? So to talk about this, we back up a little bit and we focus first and foremost on BRCA. BRCA1 and 2 are well known already because of their impact on the treatment of breast and ovarian cancer. And it's based upon this idea of DNA repair. DNA repair is an everyday process, right? the fidelity of the replication process is quite good, but nevertheless, there is going to be a regular rate of mutations during replication. And that repair happens through a couple of different mechanisms. If you have a single strand break, then you have base excision repair that gets activated, and this is a process that ultimately runs or relies in part on a gene called PARP1. When we have double strand breaks, here again we have to go through homologous recombination repair, and this relies on a variety of genes, including BRCA1, 2, RAD51, others, this ATM, these genes that you've seen on the prior slide in terms of inherited familial cancer risk. And this process leads to high fidelity DNA repair that keeps our cells healthy, keeps us from ultimately developing cancer. But at the end of the day, all cancer is a genetic disease, so by definition, a cancer cell that has become malignant has a problem with DNA repair somewhere along the way. And what we've come to recognize is the reliance of this process on BRCA and ultimately on PARP has lent a ability for us to exploit this therapeutically. So it's this concept of synthetic lethality. And again, we know that these gene mutations are common in breast, ovarian, prostate cancer, but synthetic lethality is a very simple concept that there are 2 steps required to develop lethality therapeutically or otherwise. If you have 2 intact steps, you have cell survival. If you have 1 that's deficient, you have cell survival. But if you can knock out 2 steps in a process, then we have synthetic lethality, we have cell death. And the 2 steps we're talking about in this process are BRCA and PARP. So patients who come in with BRCA deficiency, germline, have 1 step in the process towards synthetic lethality. If we can come in and we can knock out their PARP, then we can induce cell death, and this is what we're trying to exploit. So in the normal process, here's normal PARP function. You have a single strand break, PARP comes in, ends up initiating a cascade, so PARP will bind to the break point here. Ultimately, you have other genes coming in, RAD51, other proteins. And typically what will happen, once the PARP comes in, it will recruit ADP ribose polymers. You'll have high fidelity DNA repair. The cell will go on as normal. But if we come in here with a PARP inhibitor, what this does is it inhibits the further formation of the complex and traps this complex on the DNA, preventing the replication from happening, preventing repair from happening, ultimately leading to DNA instability, double-strand break, and cell death. So the point of the PARP inhibitor is to prevent repair in a cell population, that is the cancer cell population, where damage is happening at a high frequency. You're exploiting the normal inherent instability of the cancer genome, preventing it from repairing itself, preventing it from replicating itself, and therefore inducing the apoptotic pathway. So you look at this and, cell line studies, this is a typical story in prostate cancer, right? We're all used to this. Cell line studies looking at PARP or looking at BRCA and synthetic lethality go back to 2005. Clinical trials started in 2008. And in initial phase 1 clinical studies, we had prostate cancer patients who had very good responses to PARP inhibition. Okay, but there's also ovarian and breast cancer. And so what happens next is a story we're all used to because there's a lot of kind of nihilism, lack of interest in prostate cancer. No studies move forward in prostate cancer. Ovarian cancer studies move forward, breast cancer studies move forward, and by 2014, you have the first FDA approval for a PARP inhibitor in ovarian cancer. In 2013, you have large phase 3 studies that are organized, breast and ovarian cancer. The field's moving forward very quickly. As far back as 2011, when I first came here to Mayo in Arizona, I approached every company that had a PARP inhibitor with investigator-initiated study concept saying, let's move this forward in prostate cancer. And we get the familiar you know, the familiar response of crickets. They say, oh, you know, that's a great concept, sure, sure, let's talk, okay? But here we are, you know, here we are in 2017. It took until 2015 for the first report to come out looking specifically at prostate cancer. I mean, this is 7 years after the phase 1 study had already shown that there was a signal. Okay, something that we should have moved rapidly on to exploit, okay? And this study came out of Johan de Bono's group at the Royal Marsden in the UK. Very small study. And what they're showing here is they tested patients for germline mutations, and here's your BRCA population, here's your ATM population, and here's this longer list of genes associated with homologous recombination or DNA repair. And what you see here is a dramatic difference, both in progression-free survival and in overall survival with the use of olaparib in patients, the blue line, patients who have germline defects versus red, patients who do not. I mean, this, you know, you don't need a hazard ratio here to see that there's a significant difference. Now, this is a single-arm, single-institution study. This is very limited data. Okay, this is not definitive by any measure, but this is a powerful signal. And the point of this was to say, look, we need to move with PARP inhibitors in prostate cancer. This led to an initial approval by the FDA for breakthrough status for olaparib in prostate cancer. And what this means is we can get olaparib for our patients. It varies insurance company by insurance company. You know, we got to go through a process. But if a patient has BRCA 1 or 2 deficiency, in my experience, we got a 50-50 chance that the insurance company is going to let us prescribe this drug. And in my own practice, we have, you know, 30-plus patients now who've been treated with olaparib off-label with the insurance company paying for it. I tell you, it is every bit as effective as what you see here. We also now are in an era, finally, where we're having randomized phase 3 studies in prostate cancer, rucaparib, niraparib, talazoparib, olaparib. All the companies that have these drugs are looking in prostate cancer. So you're going to hear about these studies. And you know, every study is a bit different, pre-chemo, post-chemo, you know, in combination with other androgen receptor antagonists, et cetera, et cetera. There's a whole proliferation of these studies, and this is going to transform the field in prostate cancer, to be sure. Here's another demonstration of the same, and I think in the interest of time, I'll just keep moving forward, but what this one is showing us is, again, a cohort of patients with metastatic castration-resistant prostate cancer. The double dots show you patients where the defect is demonstrated in the germline versus here where it's demonstrated just in the tumor. So this is making the point, the difference between somatic and germline defects. Somatic meaning it's only present in the tumor. The tumor developed the mutation. It's not present in the patient's germline. It's not heritable, has no implications for the family. And in the metastatic patient, it's about 50-50. About half the patients have germline and somatic, half the patients have somatic only. So the way I typically approach this in my practice is what I'll do is I'll go ahead and do somatic testing. If the tumor doesn't carry the defect, then you're sure it's not present in the germline and it's a full stop. If I find it in the tumor, then I have a conversation with the patient about moving on to germline testing because of the implications for family. So at the end of the day, about 20 to 25% of patients with metastatic disease will have somatic mutations in DNA repair genes, and clinical trials are ongoing. Inherited cancer syndromes are under-recognized both in practice and in research, leading to delayed diagnosis and decreased cure rates. We need to know this. We need to identify it. This is how we're going to improve cure rates more than anything I'm going to do in my clinic. Guidelines are still evolving, and future treatment paradigms, I would say, are likely to incorporate germline and somatic mutation data as we move forward, and I'll touch on that a little bit more in my next presentation.